Okay, and the other important, before I even start, I must say that we need not be alone in this battle against inflammation. And I have to repeatedly emphasize that we should never be alone. I think we should always have other subspecialists, meaning the other disciplines, to work with us. And I don't think we should feel ashamed about it, or our ego should not come in the way. We have to get either an endorsement, sometimes it could just be an endorsement of the track we are going in, or sometimes it might have the help from the other subspecialists. So I probably would think that adding other biologicals and other agents should involve the either the rheumatologist and certainly the endocrinologist when we're dealing with thyroid. I think that's a statement that has to be emphasized and overemphasized. So the orbital inflammation per se, we all know that we need to do a very good clinical assessment. Undoubtedly, the history becomes very, very important for us to rule out whether it is an acute onset or a chronic inflammation that we are dealing with. And then we need to, as was mentioned, see, a lot of times there is a subtle difference between an inflammation and an infection. So that also has to be borne in mind. Every infection need not manifest like a very stormy presentation. So it could be a subtle preseptal cellulitis, which can manifest as an inflammation as well. So we need to keep all this in our mind and do a perfect diagnostic workup. When there is a clinical suspicion of an idiopathic orbital inflammation, again, overemphasize a complete history and examination, because the history is going to give us the clues. The examination is going to give us the clues because we don't have the diagnosis sitting right in front of us. So that is again overemphasized. Now let's go into the management part. So initially our treatment goal is to control the inflammation. That's our top priority. We need to preserve the vision. Most often in inflammations, the rapidity is what is going to compromise the vision. So that's why the urgency in treatment is very, very important. And we need to prevent the recurrence, about which I'll talk a little more in the next slide. And you have to minimize the side effects. Like if you noticed when Milind was mentioning, and Dr. Jayagayatri had a question on what do we do when steroids are not, the only way to go about. Steroids are being pumped in. See, steroids need not be pumped in. You have to take you have to pause at a period of time. And trust me, all of us who have been treating inflammations have had various hurdles in terms of treatment and outcomes. So we need to understand that steroid is not to be pumped continuously. And remember, steroids has huge side effects. So the minute you see an inflammation or a red eye, when it's not something else, and if it's dumped as inflammation, you need not aggressively step in with steroids and keep pumping steroids. So then I'm going back to the other side where I start off my management with steroids. So I see a case of myositis after I've investigated. I've seen a very good tendon involvement with the muscle involvement, and I know it's causing a lot of pain. Then my first line of management would be steroids. So what steroids do we use? We'll talk about it in detail. So now we've given the steroids. You wait for 2 weeks. There's good response, then you're in the right direction. If there's no good response, then you'll have to think of other steps. When you have a good response, the normal tendency for people is immediately start cutting down the steroids. We should never do that. We have to continue the steroids for a certain period of time and then taper the steroids. And I'll talk about that also in the next slide. No response, then stop the steroids. wash out the steroids for 21 days, and then go in for a biopsy. This should be the rule. Now, steroid therapy is something which all of us need to really concentrate on. Our main problem is we give steroids and stop it abruptly. We talk about the side effects and then we stop it very abruptly. The other problem is the compliance. You give steroids, patient responds to it very well, and they stop it even before coming to us. They sometimes don't come or review. And then when it recurs, they go to the next doctor. So that's the problem with the steroid therapy. So we have to explain upfront. So this counseling for steroids is very, very important. Be it thyroid or any kind of inflammation, I think we really ought to spend a lot of time on counseling. So we start off with oral prednisolone is 1 to 1.5 milligram per day per kilogram. So the maximum should go up to 80. Of course, if you have a 100 kilogram patient, you can't do much, but you have to step up the dose. But I think 80 should be the maximum. Okay. And then see, you should start tapering it very slowly. 2 to 4 weeks, you give this particular dose and then slowly start tapering it down. And don't stop it abruptly. And the tapering also should not begin right after any minimal response to steroids. So it has to have a nice slowdown and then you start tapering it. Now, the next question, which most of us are always anxious to know, are eager to know, when to start other medications. So you don't have a good response to steroids, and then you don't have another option. And if you still feel that you have no other option but to start other agents, you can consider methotrexate, mycophenolate, I think all of these we have been using it. We've all used this in our routine practice. But I think we need to always have another rheumatologist. Like Dr. Milind was mentioning, that we don't do it independently. It's important for us when we are not dealing with steroids, then we need to get the help of the rheumatologist for the dose calculation and also because it also involves systemic conditions as well. So we need to have that. So when do we consider the non-steroidal immunosuppression? We go for steroid resistance or partial response. Sometimes the patients don't respond very well immediately. So in that scenario, you can consider. And recurrence during the tapering or after stopping the steroids, or sometimes they do not tolerate the steroids. And I think we need to have, I'm not going into the details of how you have to follow up with the other immunosuppressions, because you have to follow a very stringent protocol, which is best done alongside of a rheumatologist for us. Now, do we think of radiation? How often do we think of radiation? We do have scenarios where the effect of the mass that is being produced by the inflammation is causing all the collateral damage. So in that scenario, you can think of radiation, where we have miserably failed with the medical management, where steroids have failed and other immunosuppression has failed, then probably we have to resort to radiation. And we have another entity called the sclerosing type, which is proven only with histopathology. So all of this I'm talking only after proving it histopathologically. So unless you prove it histopathologically, then you cannot advocate any of these treatments. And trust me, none of the rheumatologists also will take up these cases unless you have proven it histopathologically. So a biopsy is mandated, about which we'll talk. When there is a sight-threatening scenario where your medical management has failed, you may have to resort to radiation. And when there is a contraindication to steroids and immunosuppression, you probably will resort to radiation. And we talk about elderly patients who can't go through this steroid therapy, but it's very difficult to convince them for radiation as well. And there is a specific protocol which the radiation oncologist is well aware of. It will usually be a low dose. Now, what will be the prognosis and what is the recurrence? Are we written off once the patient is completely ridden of the disease? No, there can be a recurrence. So there is good response to treatment in most of the cases. The visual outcome is very good. Complete resolution is possible. Sometimes it can result in chronic disease. So we will have such patients. I'm sure I can bet on it that all of us have a subset which keeps coming year after year, month after month sometimes. And there is also a possibility that my patient would have gone to Dayakar, would have gone to Milind, would have traveled up to Delhi and come back with the same steroids or with the same kind of a discussion with the surgeons. So it is possible that there could be a chronicity in these idiopathic entities as well. So never feel disheartened when you have such patients. That's the bottom line. What are the poor prognostic factors? You have a bilateral disease, you have a chronic disease, sclerosing type. Posterior ones are very difficult, the apical ones. When there is optic nerve involvement, when there is a delay in uptake of the treatment, and when there are multiple recurrences. These are all factors which have a poor prognosis. So it's very, very important for us to have a very good follow-up and compliance. Now, for all this, the main treatment is a lot of talking to the patient. The first treatment is talking to the patient. So we also have pediatric idiopathic entity. That is, though rare, it is present. Like thyroid orbitopathy is not very common in children, but we do see a lot of patients. At least in the tertiary centers, we do come across the thyroid as well as idiopathic entity. And these are often bilateral. As I mentioned to you, this is a myocytic entity. When it is bilateral, we often term it as idiopathic orbital myositis. And often these seem to have more of an association with systemic disease. So a very good long-term follow-up is essential. Initially, it may not show up as a systemic entity, but eventually you will have a systemic manifestation in most of the patient. It could be also an IgG4 related entity. So all of these children have to be monitored very closely over a period of time. And these tend to have recurrent episodes. And the good news is it's better resolution in the children than in the adults. But you have to keep in mind other differential diagnosis, because you cannot keep treating these patients with steroids, because rhabdo is another entity which can masquerade like it's a good masquerader, and it responds very well to steroids. So this entity has to be ruled out. And you do have leukemia and lymphoma as masqueraders again. Now, leukemia, it will come to us, ophthalmologists, first, because there'll be a supraorbital fullness, there'll be a proptosis, pale faces, and you can just one test. You do a total count, peripheral smear, and then you know it is a leukemic deposit in the supraorbital region. So it's important for us to rule out all these. Keep in mind all these things. Again, this has got a lower threshold for biopsy. I feel you should immediately do a biopsy when you see a mass. And the protocol, the steroid protocol is very similar. It's again the weight related, and you need to, as I told you earlier, you have to screen these children for systemic conditions. Now, I just a few words about IgG4, because to complete this entire orbital inflammations, IgG4 is becoming more and more common now. I think we are seeing a lot of these cases. So I think we ought to know a little more about it, and it's becoming a common question in the exams as well. So it's seen in the older age group, especially the 50 to 70 versus the 40 to 60, which we see in the idiopathic entity. And unfortunately, there's a male preponderance. It's a very chronic condition. It's slowly progressive. It's not It's not something which is very alarming for the patient. So it's just a very slow process. Again, it's filling up the orbit. So it seems like a pseudotumor. It seems like the idiopathic entity, but then just one test will prove that it is IgG4. So you need to look at the IgG4 levels. Now, you also, in addition, sometimes have patients coming to us saying that it's confusing because you would have given steroids. So the patient is becoming Cushingoid, but there is also complaints of patients talking about pain during swallowing, and there's some kind of a fullness in the parotid region. So you can have a McCulloch syndrome, which is masked by the steroids that we are giving. So patients will also complain of dryness of the eyes, which again, we think that with good lubricants, we are able to support the patients. So you need to remember that these are all things that ought to be kept in mind. So you have to do a systemic screening in the form of ultrasound, and then you have to thoroughly examine the parotids, the lacrimal gland alongside the parotids, and then the lungs and the kidneys have also got to be examined very thoroughly. So here it's the IgG4 elevation is the clue for us. And of course, you need to do a histopathological examination to rule out. Again, except for thyroid, I think a biopsy is mandatory for any other orbital inflammation. Let's keep that as a simple basic rule. So that also will have to, will show a lot of lymphoplasmocytic infiltrates, and there will be extensive fibrosis in IgG4, and you will see the levels of the plasma cells are all predominant, and the treatment again is steroids initially, and then you will move towards the rheumatologist will pitch in at this point of time. It responds decently to steroids, but eventually you may have to go in for additional non-steroidal immunosuppressions or some biologicals if needed. But our exposure to biologicals is very minimal, and I think it is best to take the help from the rheumatologist and the endocrinologist. So the clinical pulse here is pain is the hallmark for wake up call now. Everybody, haltosis to lid retraction. When we have a non-specific orbital inflammation, the hallmark is pain. If tendon is involved, then it is non-specific. Versus the thyroid. So if thyroid, the tendon is spared. Dramatic steroid response, then you're in the right track. You're dealing with some non-specific entity. Bilateral disease, please think of a systemic involvement for sure, except in Jai Gayatri has got a big prize for this. Bilateral disease in adults, you think systemic. Bilateral disease in children, again, idiopathic orbital inflammation, especially idiopathic myositis. You can retain the... I thought it was some gold weight that you were going to give. So if there is a recurrence, please remember that's only because we have tapered the steroids too aggressively. Of course, as was mentioned by our radiologist, MRI is definitely superior because we are dealing with soft tissues. Anytime you're dealing with soft tissues, please go for an MRI. When you're just dealing with the bone, it's good to have a CT scan. But if you don't have an MRI access, or if patient is not able to afford, please go for a CT at least. Now here we are talking about, I think we are between food and 4 more slides, I promise. So this is a 29-year-old female with a swelling in the upper lid. How many of you have seen a scenario like this? No? So good that I'm showing you this. Have you not seen patients like this? It's not very uncommon these days. So here you just have a fullness here, swelling here, and it has been slowly increasing in size. So our first thought will be, is it a tumor? Because when you have a tumor, you're not supposed to do a biopsy. You're supposed to, if it's a tumor of the lacrimal gland, it's best to excise it completely rather than do an incisional biopsy. Okay? A tumor of the lacrimal gland, if it's well circumscribed, please take it out. Here, it is not well circumscribed and it is not following the routine. And you can see that there is some infiltration here as well. So here we need to do a biopsy. So the biopsy, so I wouldn't have just started off with a biopsy. I would have started off with the steroids, did not respond well. Then I wait for the washout. Then I do the biopsy. And this would have taken at least a minimum of 6 months by the time we have come to that stage. And then when I do a biopsy, I get to see that it's just a chronic inflammation. This I put in the bucket of idiopathic entity. Now here I have a 51-year-old male. Again, you see this scenario here. This person again underwent a biopsy and it turned out to be a Wegener's granulomatosis. Why am I mixing all of these for you is to understand the real importance of doing a biopsy. Things haven't dramatically changed between the two scenarios. See, everything has a very bizarre filling effect. It looks like a tumor, but it's not like a tumor. It's not a tumor. But this has to be by every suspicious lesion has to be biopsy and after a trial of steroids. Now here you see again a supraorbital fullness here. But here I get a histopathology of necrotizing granulomatous inflammation. And you can see that picture is not very different. Everywhere it's almost similar. Now I'll show you another entity where it is non-necrotizing. And you see the same S-shaped. You see the same pattern. You see the same diffuse involvement. It hasn't changed. But histopathologically, it is different. Now, I do have some certain surprises too. Even this fat sometimes tends to get inflamed. And I've never had a fat which is so thickened fibrotic. And that turns out to be a lipogranuloma. So even fat per se can be inflamed and give an effect of a tumor. So please remember, this is also an entity. And look at the diffuse involvement. And why are we worried? Like the radiologist mentioned, lymphoma is something that you have to keep in mind. So how do you differentiate lymphoma? Lymphoma actually grows along the bone. So if you see any fullness supraorbital, you will see that lesion growing along the bone. So that is one differentiating feature in radiology. Whereas you will palpate a mass, you will see a salmon patch, but occasionally you will have a filling effect, which will be retrobulbar, intraconal, where you have to go and take a biopsy. Now, this is a 50-year-old female. Again, this is a chronic dacryoadenitis. So you get all kinds of a bizarre presentation, all of them only differentiated in histopathology. Okay. If in a 50-year-old, if I see a lacrimal gland enlargement, I would first think of a neoplasm. I would first rule out either a pleomorphic adenoma or an adenoid cystic carcinoma, because even if it's well encapsulated, because of the longevity, sometimes with associated pain, you will think of an adenoid cystic carcinoma. So remember, we need to also remember this part. Now, this is another very unique situation where a patient had just pain and redness, which was treated with steroids, didn't seem to respond very well. But then we did a biopsy, and post biopsy, the person who did not respond to systemic steroids responded well to intralesional steroids. And he's been on good follow-up. Now, this is a 57-year-old male with bilateral, you just look at this bizarre presentation, bilateral proptosis. He's had a pericardial effusion. Okay, remember this. And multiple cervical and mediastinal lymph nodes. And this great man is on Ayurvedic medication to top it all. Okay, and this is the picture. Differentials. What will you think of? There's pericardial effusion. Multiple lymph nodes are there. Your first thought will be, somebody said it, lymphoma. But before that, we have something rampant in our country. Yes. This was a picture. Biopsy is the only gold standard. Okay. But that biopsy also is giving us a bizarre presentation. It's pointing towards a lymphoma. But what gave us the clue was so it's just not it's not adequate if you just stop with immunohistochemistry, because that also can give you some bizarre presentation. But ultimately, the tissue was sent for PCR, which turned out to be tuberculosis. Now here, this is a 24-year-old male with swelling for 2 months. And all the investigations seem to be normal, except that this is what we have. Diagnosis. If you don't say this, no lunch. I've given you all the clues. S-shaped, supraorbital fullness, superolateral aspect, correspondingly. Then I'll go back from slide 1. Dacryoadenitis. Wonderful. Thank you. And this is what it turns out to be. There is a squamous hyperplastic epithelium and squamous metaplasia. And this turns out to be a necrotizing dacryometaplasya. Okay. So here I don't need to put him on steroids. Okay. But I need to stringently follow this patient up. All right. So this is another variant. Now, look at this 25-year-old male. What is the diagnosis? Look at all this, please. Now, if I don't get the diagnosis, go back to slide 1. See, you have okay. So what should I do now? I gave steroids, but it's not resolving. What will I do? Okay, wait. And then what do I do? Biopsy. And this is what I get. It's a worm. It's dirophilaria. Okay. So the reason I want to show all this is, please remember, there is so much that we don't know. Okay. The simple fact is we assume that we've got a lot of diagnosis. I thought we are shrinking the bucket of idiopathic, but every time we are shrinking the bucket of idiopathic, there's a new entity growing. Okay. So there's so much for us to learn. And I really enjoyed every session, that is every talk that was given, because there was so much to learn from every one of them. They had so many points to tell us. And it was a wonderful session that the team, Dr. Gayatri and Dayakar have organized. So There were some people, the professors and the teachers here, taking a look at the backbenchers ever so often. And I think it has been a very useful session for all of us. Please remember, you don't all have to be oculoplastic surgeons or orbital surgeons, but you have to send a decent referral to your oculoplastic surgeons. So somewhere in your referral letter, if you put across these points, congestion over the medial rectus, there's a prominence, an acute pain, you add all those, the respect for you grows. If you were to refer to Dr. Gayatri, you have to put all these points, and Dr. Gayatri will be forced, like somebody was mentioning, they'll be forced to call back and tell you, all your points were absolutely right. This is the diagnosis. Please remember, the more you give, the more you get. Okay, so thank you so much. And thanks again, Gayatri and